Minority Quality Forum's Center for Sustainable Healthcare Quality and Equity in partnership with the Association of Black Cardiologists. My name is Kristen Hobbs, and I am the Senior Project Manager of Quality Improvement and Equity at SHC, and I will be moderating our esteemed panel discussion today. We have first Dr. Keith Ferdinand, who is a cardiologist in New Orleans, Louisiana. He was the former chair and chief science officer of the Association of Black Cardiologists and is currently the chair of the Access Committee at ABC. Dr. Ferdinand, thank you so much for joining us.
My pleasure.
Absolutely. And we have Dr. Dan, who is an ER physician, a biodefense expert, veteran, media personality, and NMQF SHC partner. Thank you so much for joining us, Dr. Dan.
Thank you for having me.
Absolutely. So quickly, we'll talk about NMQF and SHC, Association of Black Cardiologists. We'll dive into some data, talk about the ACIP recommendations for flu vaccinations, and we'll talk about some Q&A from our pre-submitted questions. So the National Minority Quality Forum was started in 1998 by Dr. Gary Puckrin, really as a way to use data to address health disparities in underserved and communities of color. That's the crux of what we do. At SHC, we use that data to build sustainable, healthy communities in every zip code. We prioritize communities of color, but we're also invested in rural communities, communities of individuals living with chronic diseases, and other underserved and historically minoritized and historically excluded populations. Our foundation is to use quality improvement and clinical education through the lens of health equity to advance health equity. And so our president is Dr. Laura Lee Hall, you know me, and our quality improvement equity project manager is Chinonso Ukachukwu, Chinny, who we call just joined. And the Association of Black Cardiologists, so they were founded in 1974 with a membership of over 2,000 health professionals, community health advocates and ambassadors, corporate and institutional members. They're dedicated to lowering the high rate of cardiovascular disease, stroke in minority populations, and they have a vision that all people should benefit equally from the reduction, duration, and impact of diseases of the heart and blood vessels. So Dr. Dan, I am going to turn it over to you to talk about flu vaccine.
So yeah, this graph basically is a graph looking at the flu vaccine by age, and you can just basically follow the graph. On the y-axis, you have the folks who are the percentage of folks who are vaccinated, and on the x-axis, you have the years. And over the past 10 years plus, you can see the data. There's been a trend towards increased vaccination with a few exceptions, especially during that 2017-2018 year in which there was a dip for all age groups. But the bottom line, or the take-home message with this graph is that if you look over time, it seems like, and it's very clear by the data, that those who are 65 and over tend to get the vaccine. And they are the groups that are getting coverage with regards to the flu vaccine over the flu season. And these are usually busier flu seasons. They're also at high risk, of course, but that's been the trend. And for other age groups, you can see also the trends. The lower the age, the more likelihood that they're not as compliant with getting the vaccine. And we can look at data on complications, but this is just a graph from CDC. You can go to the next slide. So if you look at this by state, so find your state on the map here. Again, on the y-axis is a percent that's vaccinated, and then on the x-axis, you can see each state. Find your state there so you know how successful you are, or which group is the most successful state in terms of vaccination rate, and you can brag about that. But this bottom line, they all pretty much fall within a range, anywhere ranging from 40% to 64%, with the highest being in Rhode Island. Next slide, please. So flu vax by race and ethnicity, this is important and very crucial for us. When you look at it again, on the y-axis, you have the percent vaccinated, and on the x-axis, you have the number of years. But the Interesting part is that you can see for the Black and non-Hispanic population, we seem to fall into the lower group. And for those that are other races, non-Hispanic, are the lowest in terms of that trend. And that could be a reflection of either communication, misinformation, or lack of information, or lack of trust, or lack of access. I mean, there are many things that can affect this, and we're trying to change this graph so we can push this graph up, actually, and move it up, pushing towards 60 to 80%, if not even better. So how do we do that? Those are some of the things we'll talk about and how we can improve that. But again, you can see the trend for our white non-Hispanic population. They seem to have the highest rate of compliance, or at least with receiving the vaccine. And that can reflect a number of different biases, which we'll go into in detail. Next slide. This actually for Dr. Ferdinand, since this is his area, but I think it shows the data in terms of those who are getting vaccinated versus those who aren't, and those who actually have heart disease. So with that, I believe I'll pass it on to Dr. Ferdinand.
Thank you, Dr. Dan. I'm a cardiologist, but the reason I'm really interested in this particular area of study is because if you look at the patients who get sick or hospitalized and die from the flu, disproportionate, it's the same patients we see in cardiovascular disease. So the Association of Black Cardiologists wants people to live long, healthy lives. And that includes not just treating the traditional cardiovascular risk factors, but increasing immunization. So on this slide, you see the data. The older persons who have heart disease are getting flu vaccinations up to 80%, but the younger persons who still at risk, who are under the age of 65, only about half of them have flu vaccination. Next slide. So when we look at the complications of the influenza virus, next slide, you see the first complication, go back one, please. The first complication are the direct effects on the respiratory tract. And it is a respiratory virus. It includes exacerbations of asthma, chronic lung disease, sinus infections, bronchitis, and pneumonia. But there are also indirect effects, which also can be very dangerous and lead to an increase in hospitalization and death. We have data now that persons with heart disease, especially older persons who get the flu, have an increased risk for myocardial infarction, ischemic heart disease events, and cerebral vascular disease, including strokes, and can actually cause worsening of chronic kidney disease and diabetes. Next slide. So let's look at the potential complications that would affect the ability of our patients to recover more quickly from influenza. They include pneumonia. It is a virus, but with respiratory insufficiency, especially in patients who are hospitalized, there'd be superimposed bacterial and even fungal infections. Of course, respiratory viruses will exacerbate asthma, chronic lung disease. Myocarditis. The flu can have a direct effect on the myocardium, and with the increase in inflammation, actually cause myocarditis even without direct infection from the virus itself. And worsening of heart failure. Patients who already have heart failure, especially with reduced ejection fraction, have decreased cardiac reserve. So having a very serious inflammatory state will actually make the heart failure worse. Myocardial infarction. We know that the atherosclerotic lesion is not just a passive occlusion of the vessel. You have a mixture of white blood cells, inflammatory markers, and platelets. In the presence of a viral infection, it may actually cause acute rupture and acute myocardial infarction. Stroke and encephalitis is the same. Sepsis and multi-organ failure. Next slide. So let's look specifically at some of the data. These are very publicly available. Having heart disease and then getting the flu increases the risk of myocardial infarction. Cardiovascular hospitalizations, just if you look across the population, increase about 24% during peak flu season, showing that there is a link between having an acute coronary event and getting the flu. Patients who have heart disease are 10 times more likely to get a myocardial infarction within 3 days of the flu. Persons with diabetes are 6 times more likely to have flu-related hospitalizations. And some of the work we're doing in New Orleans with sustainable healthcare is directly related to diabetes and the flu. And I'll show you an example of that shortly. If you look at persons who die from the flu, it's on either side of the age spectrum, very young infants and children, but about 90% of the increase in deaths are related to persons who are 65 years and older. Annual vaccination, therefore, is necessary for our cardiovascular patients, especially our older patients, to protect them from long-term complications. And as Dr. Dan has already shown the data, there are disparities in the uptake of flu immunization, lower in non-Hispanic Black and Hispanic Latinx population as compared to white populations. Next slide. So ACIP recommends that anyone who's 6 months or older and does not have a contraindication get the flu. And they suggest you speak with your doctor or other health provider if you have any questions. I think every visit should be an educational opportunity in which we talk to our patients directly, not only about their blood pressure, weight, temperature, A1C, lipids, but about their immunization status. Next slide. Some of the work that we're doing in New Orleans, as I mentioned, is with Sustainable Healthy Communities and the Healthy Heart Community Prevention Project. Healthy Heart, for decades, led by my wife, Dr. Daphne Ferdinand, who's a PhD in nursing, has gone into the community. Along with the late great Elijah Saunders in Baltimore, we pioneered using barbershops, beauty shops, sporting events for hypertension and cholesterol screening. Next slide. Here are some examples, pre-pandemic, of course, in which I would go into the neighborhood centers, talk directly to seniors about their cardiovascular status, diabetes, lipids, and blood pressure. Next slide. And we would go directly into the church and other faith institutions, again, addressing patients directly so that they can have shared decision-making when they see their own provider about their cardiovascular health and their glucose. Next slide. But what we've done most recently, and again, this is pre-pandemic, and we're going to start this soon, hopefully, is that we would partner with neighborhood pharmacists to offer flu shots at the same time we were doing education regarding diabetes and cardiovascular disease. If you recall the data that we just discovered, patients with diabetes and heart disease are at the highest risk for complications with the flu. So it's not enough just to talk about their blood pressure, their lipids, and blood sugar, but to offer immunization for the flu. Next slide. This is from the American College of Cardiology. It's their CardioSmart patient education platform, and I'm on the steering committee for this. And this is one of their infographics. The red box says to the patient, flu vaccine can help you lower your risk of heart attack, stroke, and heart failure, avoid dangerous complications, and stay healthy. We show data that supports that. And at the bottom is the action, what the individual patient can do. Of course, take care of your cardiovascular health with aerobic activity, eating a heart-healthy diet, of course, don't smoke, and take medications for cardiovascular risk factors. But don't forget, get vaccinated. Next slide. So we took brief moments, Dr. Dan and I, to show the data. We discussed what we can do to better improve the lives of our patients. Perhaps now, Kristen, we have time for some questions and answers.
Absolutely. So let me stop sharing. Okay. We will go through some of our pre-submitted questions. So first things first, what can cardiologists do to promote flu vaccinations to their patients? I know, Dr. Ferdinand, you talked about talking about their vaccination status at every single visit. What does that mean in practicality, and how do they even bring it up?
Well, I'm a professor, I'm an educator, and I do a lot of writing and research, but I still have clinic. And when I walk into the room, I sit down, eye level, culturally competent, literacy appropriate level. That means don't use all the big, long Latin words. And the first thing I'll ask the patient, have you gotten your vaccinations? And I ask about COVID-19 vaccinations because they are the same patients who had high risk from the flu. And I ask about flu immunization. I also go to shingles and pneumovax. I'll take it all the way. It doesn't take that long. You just need to tell the patient that you're a trusted messenger and that you want them to be healthy. And it's just not enough to just look at the traditional cardiovascular risk factors.
Absolutely. Thank you for that. This next question, I think, for the both of you to answer, are there any instances where you would not promote a flu vaccination to your patients?
Dr. Dan?
Yeah, I don't know that there's any main instance except if they had an allergic reaction or an allergy to a known component of the flu vaccine. And in this case, where even sometimes people had some egg allergies, we've gotten beyond that actually, where they actually they have allergists on site or where people are desensitized and actually certain components don't even have a an antigen or something that would make your body be offended, so to speak, where your body would react in an untoward way to you. So there are ways around a lot of those things. So it would be only if they had some severe allergy, but you would talk with your doctor and they would make the arrangements to make sure that you're okay to get this type of flu vaccine. There are many variations of the flu vaccines. We have flu mist and other types of vaccines, those that are intranasal, those that go into your muscle. So there are ways around that. That's not a reason. As my colleague, Dr. Ferdinand, had just mentioned, those risks with regards to heart disease and underlying medical conditions that you have are not reasons not to take the vaccine. So they're really not that I can say, except that little extreme case. And even under that extreme case, we have a workaround. So we have a cheat code for that.
You know, I'm glad you said that because I really couldn't think of anyone that I've told not to get the flu vaccine. I know the intranasal with the live attenuated virus should not be used in persons who are over 50 or immunocompromised. But other than that, boy, I couldn't think of anybody. So you gave us the understanding that if you do have problems with severe allergies, then you should talk to your physician, perhaps be seen by an allergist at the same time. But there's really no real bad complications that you have in the overwhelming majority of people who get the flu shot. And the reactogenic reactions are minimal.
Absolutely. So if your patients are giving you pushback, there's really never a case where the flu vaccine.
Well, Dr. Dan said there's a workaround.
There's a workaround. I love it. So next question, we talked about what clinicians and cardiologists can do to improve access. What can the system do? So we know there's a lot of issues going on with system access and policies within systems. What can the system do to improve access to flu vaccinations to patients living with chronic illnesses like heart disease?
Well, let me go first. You know, in the hospital setting, there's a lot of controversy around COVID-19 vaccination and mandates. But for years, you could not work in a hospital setting if you didn't get flu immunization. And if you did not want to get the shot, you would have to wear a mask at all times. This is even before COVID-19, so it was unrelated to COVID-19. Specifically, how to get the word out to the community. I think as we go back into the community with some of our outreach programs, the ABC has what they call the Spirit of the Heart, where they screen thousands of persons and talk to pastors who are trusted messengers. We should bring with that information about cholesterol, blood pressure, diabetes, the importance of flu vaccination. It's one of the best things we can do for our high-risk patients. So we should build it into the platform of cardiovascular risk reduction.
Absolutely. You spoke quickly, Dr. Ferdinand, about really breaking down the medical terminology when you're talking to patients so that it's easier for them to make informed decisions about getting vaccinated. Can both of you expand on the importance of culturally competent conversations and culturally responsive conversations, especially for Black and Brown communities?
Yeah, this is huge. I'll go first. This is important, and Dr. Ferdinand mentioned this. There's something about just having simple words, and actually finding analogies that people can relate to. It's not that people aren't smart and can't figure things out, but why give them something it's more difficult to understand and digest. Why not keep it simple? And that's important in terms of behavior, and also for them to be able to be the trusted messenger for their family members. Because if we educate and share the information in an accurate, digestible manner, without the medical jargon, without the Latin, as Dr. Ferdinand also mentioned, they can then propagate that message and be a voice of reason among their own area or sphere of influence. I think it is important that we put that in everyday practice. People might think it's very easy. It's not that easy to actually break down some of these medical information. So it takes practice. So the onus is on the clinicians, the scientists, the doctors, the nurses, all healthcare providers, allied healthcare system, to be able to actually provide this information in a digestible, tangible way so that people actually understand and they can influence their healthcare and they can follow up with their needs and they can ask questions. You know, there's a lack of time sometimes between patients with a busy day and a busy schedule. And taking that time out when we do sit down and making sure that it's understandable can go a long way in terms of their healthcare, preventive healthcare, and also propagating that message to their loved ones. So I think it's very important. Dr. Ferdinand?
Oh, absolutely. I'm going to give an example. It sounds like science fiction, but this is a real patient that I saw within the last month. He was an African-American male in his mid-60s, and the electronic health record can be really helpful in terms of documenting care. But like any computer program, you can have reports that are hidden in files. You have to go to the lab, click on the results before you can really tell what's going on. So while doing my cardiac follow-up, I noticed the patient had had a biopsy of his kidney approximately 3 or 4 weeks prior to me seeing him. And I looked into the folder, and in the path report, it said renal cell carcinoma. So I told the man, I said, "Did you know you had cancer of the kidney?" And he was shocked. He started to tear up a little bit. "No, nobody told me." So then I showed him his report. I told him renal means kidney. What carcinoma means, it just means a tumor that grows and it's like cancer. I couldn't figure out what happened. There are two things. One is because it's a teaching hospital, perhaps a fellow or a resident did the biopsy, sent it to PATH, PATH put it in the record and nobody followed up. The fellow or resident may have rotated off the service and nobody really looked into his record and informed him. The other thing that might have happened, and Dr. Dan, you spoke directly to this, I introduced it, but you followed up. Perhaps somebody mumbled to him, "You have a positive biopsy report for renal cell carcinoma, we're going to refer you to oncology," and walked out the room. And the guy just sat there because what does that mean? It means nothing. It means nothing. So it's a real problem that we have in medicine. It's something we need to overcome. We know that concordance between the doctor and the patient, the provider and the patient may be beneficial because we understand that just because a person doesn't understand our long Latin terms doesn't mean they're unintelligent. And there's no real benefit of standing over the person and mumbling at the door as we leave, "You have a positive biopsy with renal cell carcinoma." That's not informative. It takes us off the hook. And then refer them to oncologists. What the heck does that mean? So we need to do better. We need to take time. It doesn't really take that much time. I do it on a regular basis. Just sit down, talk to the patient, culturally competent, literacy appropriate language, and the patients really will thank you for it. In fact, they may say, "You're the first doctor who ever told me that."
That's a very sad story, but I'm glad you were able to get him the information he needs. I think that speaks a lot to empowering patients when they're speaking with their doctors. It can be very intimidating to even go to the doctor for some patients because not only, you know, are you being given all this medical jargon, but doctors, you guys are very prestigious for the general population. And so some of that can be very intimidating. And so I think it's very important, like you said, to take the time and break down those barriers. So speaking of questions, can you, either of you, think of any questions that your patients may have about flu vaccines and getting vaccinated that may help other clinicians if you answer them?
Well, I have one. Patients will often say, "I don't get the flu shot because I never get the flu." And, you know, that may be true. You're never in an accident until you have a major crash on an interstate highway and you're disabled for the rest of your life. So what I tell patients, well, I'm glad you never got the flu, but we want to protect you. You know, you're a little older now, and because you have heart disease, or whether it be hypertension, heart disease, chronic kidney disease, conditions, diabetes that are so common in our communities, I can usually find something as a hook and say, well, you're older now, and we're talking about decreasing risk. And here's the example I use, and everyone can borrow it if you feel it's appropriate. I'll discuss with them driving along on an interstate highway, and you're doing the speed limit. You're moving along pretty briskly, 60, 65 miles an hour. These young men, and it's almost always young men, will come past you going 110, 120 on a motorbike or motorcycle. And they go so fast that they will actually physically lay out on the bike. Now, when I mean lay, I mean just like you're laying on the beach, they'll lay out on the bike, spinning past you at 110 miles an hour. They don't have on a jacket. They usually don't have on a helmet. I will tell the patient, you know, that's really risky behavior, but they feel fine. So we have to recognize that you're at risk. And I'm glad you never got the flu before, and I'm glad you feel okay, but I'm trying to protect you from being hospitalized or dying unnecessarily.
Yeah, that's real. And one of the things we say in the emergency department, we call those body donors, literally, because we really are concerned about that. May be tongue in cheek, but the point is that's extremely risky behavior. But to your point of what you're saying, insurance is the best policy. Trying to protect yourself and preventive approaches is most important. So even in the case that you gave, wearing a helmet, not going that fast, all those things are important. So getting your vaccine and protecting yourself, just as a double layer of protection, you know, I think it's definitely important. So hopefully people will listen, but everybody does make their own decision. We just try to provide tangible, understandable, digestible information for people to then make their choice as a shared mental model, as we usually say in medicine.
You know, I find, Dr. Dan, most patients will get that example when I give it to them, because most of us, I've had that experience, and I would think you may have also, of driving on the interstate and having one of the young men zip past you going 110 with no protection, but they feel fine. Risky behavior doesn't mean the same as feeling bad. So when they tell me I've never had the flu, I feel fine, I'll then go straight into that example, and then they'll get it. They'll kind of, yeah, I see what you're saying, Doc.
Absolutely. Risky behavior isn't the same as feeling fine. So we can't forget we're in a global pandemic still, right? So we hear a lot about myocarditis with the COVID-19 vaccine. Should we be concerned about myocarditis with the flu vaccine itself?
The myocarditis with the COVID-19 is actually quite rare. It was mainly seen in young men under the age of 35, and it's not the same. Myo means muscle, cardio is heart, itis is inflammation. All myocarditis infections are not the same. So with the mRNA, what we think it might be is just a reaction to the immune system be upregulated in a younger person. It's self-limiting. It tends to go away in 3 to 5 days. Sometimes persons have to take NSAIDs. They may have to feel tired for a few days, but it's not really that much of a common problem. If you then look at COVID-19 infections, as we talked about the flu causing myocarditis, COVID-19 is also associated with myocarditis, and the risk of getting COVID-19 and myocarditis from COVID-19 multiple times greater than that of the risk with an mRNA vaccine. I've been vaccinated. My family's been vaccinated. I have grandchildren who've been vaccinated. So my message related to influenza vaccination, which I've also done, and related to COVID-19 vaccination, I'll tell patients, I wouldn't ask you to do anything that I wouldn't do, or I wouldn't ask my family to do. And that's a powerful message. Let me make one point about the staff. And Dr. Dan is in the emergency setting, and he knows that this may be true, something I've experienced. You can even spend time and do the right thing with the patient, sit down, talk to them about risk and what you should do, for instance. They'll go to the front desk as they're leaving and lean over and ask the non-medical staff person, what do you think I should do? Should I take this medicine? Should I let this doctor do this procedure? They get that opinion. So we probably need to make sure that our staff are educated and vaccinated, because they're going to be advocates, but they also can be somebody who says, yeah, he always say that, baby, I wouldn't take that shot. They'll destroy your 10 minutes of culturally appropriate, literacy appropriate education with that one comment.
I totally resonate with that message. We've seen that a lot, where a lot of allied health professionals were like, "No, don't take this" or whatever. And there's a level, we say there are levels to this, and there's a knowledge base. So we have to then bring them aboard with that knowledge base and impart that to our staff. So everybody's walking in lockstep, and it's not a group think thing. It's just actually understanding the data and knowing what it is. And to your point about the myocarditis, yeah, we do see it in the pediatric population a lot. But the point that Dr. Ferdinand was making was pretty much clear. And I think I just want to emphasize that getting the virus itself, the infection itself, that risk of having myocarditis or the inflammation around the heart or the sac around the heart, and it causing complications and can lead to death actually, is definitely higher. So getting the vaccine is not a risk for that. And the population, which you did mention, definitely my kids fall into that. I have teens, 3 teens, and it's usually within the males 16 to 20, I think it was 36 was the high peak, and at the second dose of the mRNA vaccine. For the flu, it's not really been that much. We don't really see it typically with that, but I would say getting the virus itself, the infection, when they get it, then they have risk of having that complication. So you want to prevent that, and that's what we really want to focus on. So thank you.
Absolutely. I'd rather have the vaccine, both vaccines, than either of those viruses. And that's also something that we really focus on at NMQF and SHC when we do quality improvement in clinical education, is threading the entire clinical education through the entire practice. So from the registration clerk to the medical assistant to the nurse, all the way into the physician, because as you said, you can have adverse health outcomes if you don't. And our last question is really about pediatrics. I think you just mentioned it, Dr. Dan. Children who have heart-related conditions, what are their risk factors if they catch the flu? Are they the same as the older adults?
Yeah, so this is a great question, and Dr. Ferdinand may be able to comment on this also. I would say the risk factors, or at least the high risk populations, the kids I would be worried about are kids with special needs. So these are your kids who may be on a ventilator, who may have heart disease, who may have Down syndrome, which also means they also have heart disease or some type of heart problem. Those who have neurodegenerative disorders, these are the kids who have seizures or may have cerebral palsy and all the other constellations of diseases. So they fall into that category of children with special needs. They need other access and other things, and their immune system is a little bit different from the regular child. And how they present is a little bit different. They might be nonverbal. There's certain cues that the parents or the caregivers are in tune with that other providers aren't. So they know those signals. But those are the kids who are at risk. They may have kidney disease. I mean, any number of chronic diseases that they may have, they're at risk. They should be getting the flu vaccination because it can be very devastating. I've seen them. I've had to intubate or put a tube down their throat to help them breathe and send them to the ICU. And some had to be flown out to other areas. They've sometimes received ECMO, which is extracorporeal membrane oxygenation exchange. But the bottom line is basically we give them an artificial pump to help pump blood around their heart and around their lungs into their brain. And that's really kind of like a bad sign. So the point is, any kid who has those special kind of needs, they should be vaccinated. Definitely talk to their pediatrician. They are definitely at high risk, and we see it with influenza every year. And we see it with any number of viruses anyway in terms of infection. So they are the highest at risk. And that doesn't mean those kids who don't have special needs don't require it. We want to protect them too. But definitely if you have special needs, it's kind of one of those, it goes without saying kind of thing. And the pediatrician will definitely bring it up for them. Dr. Ferdinand?
No, I agree, Dr. Dan. There's not much I can say to amplify that. There is one point that I would like to make. We've had kind of a proof of concept that flu immunization and what we call mitigation, that's wearing the mask, washing your hands, social distancing, works. Now, you're probably thinking, I'm talking about COVID-19. No, I'm not. I'm talking about influenza. During the pandemic, we had very little influenza, and there are 2 reasons for that. One is there was an uptake of flu vaccination in 2019. They called it COVID-19 because it was first discovered in Wuhan, China in December of 2019. Well, starting that fall in 2019, the federal government, along with the nonprofit professional organizations, had a big push for flu immunization. It was up 9 to 10% that year. Secondly, once we discovered that COVID-19 was ravaging the community, we didn't have vaccines, if you can remember, early 2020. So we were telling people, keep your distance, wash your hands, wear your mask. That's what I call mitigation. And that combination of things, along with the natural history of flu, meaning the flu comes and the flu goes, we really didn't see much. I don't know what's going to happen in late 2021 going into 2022. But I think as a society, we should continue the push for flu immunization. And I personally think, especially if you're in a crowded setting or an indoor setting, you still wash your hands, wear your mask, and socially distance.
Amen. Don't take that mask off. I think I'm very nervous about this flu season because people are really coming out of those mitigation tactics. But that will conclude our questions. And as we wrap, I would love to see if either of you have any parting words for the folks watching.
I'll let Dr. Dan go first since he led off.
Thank you, Dr. Ferdinand, and thank you, Kristen, and thanks to Center for Sustainable Healthcare and ACB. I think this is just, again, one in many series of conversations that we need to have with each other as allied health professionals, that we need to have with each other as community members, and as individuals who care about our community, public health, and just looking out for our neighbors and having that sense of community. So it is important. I think prevention is what we've been trying to emphasize here. We've given you the data, we've given you the information. Hopefully it was digestible and understandable. We've tried to stay away from jargon and medical speak, but we do some education all in this whole process, and that was great, where we may use that word, but we explain what that word means. So when you hear it again, you actually even know a little bit more without having to go to medical school. But you also have some action items that you need to take account of, and you need to execute, meaning specifically talk to your doctor, get your flu vax, get your COVID vax, and any children who are special needs, make sure they go see their doctor and they get their vaccine. We don't know what's going to happen in the fall, winter, as the weather is getting colder, but we want to make sure we are doubly protected. Our insurance policy, as Dr. Ferdinand alluded to earlier. So with that, be safe, be well, and I'm done.
I agree 100%. I'm not going to say much because it was so clear. The reason we're doing what we're doing is because we should have trusted sources of information. I don't think it's good enough to just go on to Twitter or Facebook or your cousin down the street and get their input. There are certain persons, there are organizations that have dedicated their lives to making life better for people. And we're trying to do the best we can. We're simple human beings. We don't have all the answers, but we're trying to give you the best information we can about flu immunization and protecting yourselves against unnecessary death and disability. So I thank you all for this opportunity.
Thank you both. And with that, we are signing off. Thank you for joining us.